Welcome to Community Matters. My name is Jonjy, and today I'm joined by Dr. Gisela Velez. She's a board-certified ophthalmologist and retinal and uveitis specialist at the Central Massachusetts Retina and Uveitis Center. She is also currently a clinical scientist at the University of Massachusetts and a member on the medical staff at the Neshoba Valley Medical Center and St. Vincent Hospital in Worcester. She is the author of numerous scientific articles in peer-reviewed journals, including Research on Treatment for Ocular Inflammatory Diseases, Intraocular Lymphoma, and Novel Drug Delivery Systems for the Eye. She was awarded an NIH grant for physician scientists and continues her research into complications of retinal detachments. She was also named Boston Magazine's top doctor. She is supported by her wonderful family, Stephen Bruzy, also an ophthalmologist in Ayer, and 3 wonderful children, Genevieve, Adriana, and Christopher. Dr. Velez, thank you so much for joining us.
Thank you for having me.
Can you share with us your story of how you became a retinal specialist?
So, I started medical school with the intention of being a surgeon. And as I went through my rotations in medical school and got exposed firsthand to the different specialties, ophthalmology was nowhere in my radar. I had very little contact with eye specialists and ophthalmologists, but I did a rotation because I felt that was like a little bit of a gap in our education. And I fell in love with everything about it. The interaction with the patients, the machines that we got to use to examine, diagnose patients, everything to me all of a sudden was fascinating. And that's when I decided, wow, this would be a very neat thing to do. Then when I went through ophthalmology residency, you get trained to be a medical ophthalmologist and a cataract surgeon. That's your basic ophthalmology training. And you go through your different rotations and to get firsthand experience with the different subspecialties. And what fascinated me about retina was the unpredictability. No case is ever the same. Things are always changing. There are subtle differences in every case, and you have to be willing to and able to adapt and think on your feet. And I think as a surgeon, that was very attractive to me. And this was right at the cusp of the revolution of new injectable treatments for the diseases that we were all fighting with. Diabetic retinopathy and macular degeneration and all these things. So right around that time, all these new treatments were coming out, and that just made it scientifically and clinically fascinating. So I decided to become a retina specialist. I did a uveitis fellowship because I have always been fascinated by the immune system and how our bodies react and the role that it plays in disease. So it was actually an Ocular Immunology fellowship at the National Eye Institute that I did. And I think those two things combined really gave me the breadth and confidence to be a good retina specialist.
Wow, fascinating. It's a very exclusive area, retina, and I remember you told me it's like only 2 of you in the whole Worcester area, something like that.
Oh no, there's quite a few more of us.
All right,
Yeah.
it's still in the in the tens, right? It's not,
Right.
that many.
It's not that many, but there's a few. Worcester has a good population of retina specialists that are working very hard taking care of patients, and a lot of them are very esteemed colleagues of mine. So,
can you tell us what is the most common condition you treat?
So in retina right now, the most common diseases that we face on a day-to-day basis are diabetic retinopathy, which is basically when diabetes starts to cause damage to your retina. Right. And you have to think, if you think of the eyeball as a camera, the retina is basically your film. Yeah. Without good film, you can't have a good picture. It is an extension of brain tissue into your eyeball and very, very subspecialized. And diabetes can cause a lot of damage over long periods of time. So we see a lot of these patients coming to our office for diabetic screening and then for treatments for diabetic retinopathy. And macular degeneration is another very important disease. Most commonly, as we get older, it's a disease of wear and tear of the center of your vision. Often we get, patients get choroidal neovascularization, vascular proliferation, things that we need to treat with injections in order to preserve the integrity of the retina and maintain that vision.
Wow, that's really interesting. quite a very involved field.
Yes.
So, and you do surgery, of course. I had the opportunity to come and see you work in your clinic, and you have an amazing practice.
Thank you.
You also have a lot of excitement. You know, I remember there was one case, there was a retinal detachment, and had to immediately take the patient to surgery. What was the most exciting case you ever had?
So the most, I would say the most interesting, not exciting, but I think, for me, I try to learn something from every patient I see. You know, I don't ever think of myself as being done with the learning process. Every day you learn something. Every observation has value. So the most interesting patient I ever saw was a patient that came to me after seeing the experts in Boston and being told that she was going blind and there was nothing they could do. They had done an ERG, which is like an EEG of the eye. It's an electroretinogram, and she had flat curves, and basically the retina was not producing an electrical signal. And when she came into the office, I looked at her and I could tell that there was more to this patient that met the eye. When I got the medical history, good pun, yes. And when I got the medical history, she brought to light that she had colon cancer about 15 years prior, had a lot of surgery to address the colon cancer, and we did some lab work to look for malnutrition, and sure enough, realized that what she had was a malabsorption syndrome that was giving her a pseudoretinitis pigmentosa type picture. Her retina looked normal, but because she was malnourished and vitamin deficient, she was not producing an electrical signal appropriately, and that's what was causing the loss of vision. And she got immediately treated for this, and her vision recovered from legally blind to almost 20/20, and she got her life back. And I think for me, the biggest lesson, and that the reason it's so memorable, this patient, she was my patient then for many years, is that we can never forget as doctors, no matter what our specialty is, to look at the whole patient. Never forget we're treating the whole patient. The whole patient is always important, and you have to look at your patient and ask an appropriate medical history, and everything matters. And never forget that you are, first and foremost, a doctor of the patient, not the eyeball.
Right, absolutely, and an important lesson. So many big terms. So my understanding is you basically identified a problem that is a general problem, like malnutrition, and so it would probably not be as usual to see those kinds of cases, but you said, well, and that was actually came from an expert hospital, and they said, there's nothing we could do, but they sent them to you, and you like Dr. House, you identified the problem.
It's not a common problem. It is, you have to be very, very malnourished to get to the point where you're losing vision from it.
Yeah.
Having said that, and people forget, we live in the United States, and people with this level of malnutrition are they're not supposed to be commonplace, but you can't forget that, it still can happen.
Yeah,
and that's why the patient history and the patient medical history is so important. And all this lady had was just malnutrition.
Yeah, wow, that's amazing. So you actually saved that lady.
Yeah. I guess.
You're so modest. Yeah, I guess, I'm just Batman. It's not a Clark Kent in real life.
Just doing my job.
Very nice. So when you deal with retinal problems, I know that you said diabetes, macular degeneration, most common cases that you treat. There are a lot of new therapies coming out, especially for the eye, genetic stem cell type therapies, like super advanced. What is the newest therapy that's come out?
Well, fortunately and unfortunately, right now in the past 10 years, we've had a revolution in how we treat these diseases. Laser used to be standard of care for the treatment of diabetic retinopathy, and at one point it was for macular degeneration as well, especially the wet kind. And right now, the advent of injectable drugs into the eye, in particular, particularly anti-VEGF agents, drugs that inhibit a particular growth factor called vascular endothelial growth factor, which is very important in all these diseases to stimulate the disease. They have become the standard of care, these injectables, and how they're used and to treat these diseases has been revolutionary. We've gone from an era of being able to merely slow down vision loss to, in many cases, recover vision in these patients, and that's been wonderful. The flip side of that is that we're still in the anti-VEGF era. So there's a lot more work that needs to be done to get to the next stage, which would be stem cell regenerative therapies, neuroprotection, where you actually treat patients with medications to protect cells from dying, and that gives you more efficacy and better vision. Theoretically, we're still working on these. There is a long and ample pipeline of medications that are making it to clinical trials that are trying to address all these new approaches that would supplement what we're doing now and make what we do better. But there's a lot of research that still needs to be done. So my practice is actually very heavily involved now in clinical research because we believe in bringing to our patients the latest in treatment and making these choices accessible. But I also vet these protocols very carefully because I want to make sure that whatever research protocol I bring to my practice and offer my patients participation in is something that's going to be worth their time, and it's something that's going to be safe and productive for them. And I think the key right now is to stay, as a retina specialist, is to stay active in the field and active in the research process because there's a lot to be done still.
Yeah. Stem cells. I remember you had mentioned once how the issue with stem cells, right, is that it may not turn into the kind of cell you're looking for. Mm-hmm. What is your main opinion about stem cells?
Well, I think there is potential there, and there have been some promising preliminary studies, but we're still trying to figure out how to get stem cells to go to the right place and do the right thing. And the thing about the retina is that it's a very specialized layer of tissue. It has multiple very specialized layers that connect to each other in very specific ways. Every cell has a purpose. Every cell is committed. And to take a cell, like a stem cell, that doesn't have a purpose and doesn't know where to go, and tell it to turn into exactly one of those cells is very difficult. And to go to the right place is very difficult. There's progress being made. And I think we will see it, but it'll take some time. Yeah. It'll take some time.
Interesting. Do you think that we'll ever get to the point where we can start to regenerate retinal tissue?
Everything's possible, but I don't see it happening. I don't see it happening in my lifetime. I mean, I think part of the problem is again the specificity of retinal tissue, and you learn everything from different things from different animal models. We know that in reptilian eyes, retinas regenerate. So when a retina is injured, there are cells inside the retina that immediately take over the process of differentiating and recreating the damaged retina exactly the way as it should be. There is that power of regeneration. In mammalian systems, so you have the frogs and the lizards, they can do that, and then you have the mice and the rats and the people, and they can't do that. And what we're still trying to figure out is what's the difference? Okay, what are the genes that in one organism get turned on or off to allow this to happen, and in another organism turn on and off to inhibit it? And once we figure that out, we might get to that point. But it's a very difficult thing to do. Regeneration, I'm not sure we're going to get there, but there are a lot of very smart people working on that, actually.
It's very reassuring to hear. So I always think about how interesting it is to treat so many patients. How many patients do you treat every year?
About 2,000.
Wow. It's incredible, because I remember when I came to your clinic and there were so many patients with eye conditions. It's amazing. So I know that you talked a lot about Mueller cells in the past, and your excitement around this particular type of cells. All right, call me out. I don't know what a Mueller cell is.
So it's a supporting cell in the retina. I'm a Mueller cell groupie. It's because I've been doing research on these cells for a while. I had been until I switched my focus to the clinical work and the clinical research. And they are supportive cells in the retina that actually are very long. They look like very long aliens. They have big pot bellies and puffy heads and big feet. With very long limbs, and they're glial cells. They're structure cells that have been thought for a long time to just be there for support. They cross the retina from inner layer to outer layer, and this is a little bit of a semantic, but from top to bottom, basically. And supposedly they were there all the time just to transport stuff back and forth. But we are slowly learning how important these cells are, and the health of these cells is in retinal disease and maintaining retinal health. And what an important role they play in multiple retinal diseases, diabetes, macular degeneration, and even possibly glaucoma. And so it's often been, Mueller cells have often been overlooked as not important, but they are slowly becoming a focus of attention among people that in the industry that are developing new drugs for retinal diseases, and a focus of attention among researchers in terms of a target for treatment of retinal disease, and that's an exciting thing to see, because it's a shift in the paradigm on how we think about retinal diseases, and we'll see where it takes us.
That is so cool. This is so fascinating talking with you, because this is like, this is like hard science. This is really cutting edge.
Yeah.
What is the most interesting thing about the retina?
The most interesting thing, for me, the most fascinating thing about the retina has always been how incredibly specific and specified the cells that make it are. I mean, the retina has it is incredibly efficient at creating very quickly, with chemical reactions, an electrical signal that your brain interprets as an image. That's the role of the retina. And there is this, it's like a dance. It's like a beautiful dance, the communication between these different layers and different cell types and creating that retinal signal. And for me, what's fascinating is how this little sliver of tissue that's no thicker than tissue paper when you touch it and you do surgery on it can do something so incredibly complex.
Yeah.
And can do it for such a long period of time, throughout our lifetimes. I mean, it's just incredible.
Yeah, that is pretty amazing. And it's fascinating to think about how involved the eye is. We've come out with, as you mentioned, like the film, we got cameras, and it just lends to, I guess, a couple of questions. When you are dealing with eye issues, and it's a very delicate area of the body, how squeamish do people usually? I mean, like this on the squeam factor, how do you overcome that? My first consultation with patients is always very extensive, because this part of the conversation is most of what that consultation is about. We talk a little bit of the disease, we talk a little bit about the treatment, and then you come to the point where you tell patients that you have to inject this into their eyes, and that's where the conversation really starts, because most people are going to be very apprehensive about having needles come into their eyes. And I think there's no way getting over that. I mean, our brains are not programmed to allow that to happen. And so part of it is getting the patient to feel comfortable with you
and to get to know you, and taking the time to sometimes say the same thing over and over and over again. Because what you want to create is that level of comfort where the patient realizes that, okay, this is an icky thing to do, but I'm comfortable with this person doing it. And that's really what 90% of this is. And it's all about relating to that patient in a way that allows them to overcome that fear with that little bit of confidence in what you're doing.
Absolutely. Well put. What is it like being an eye surgeon?
It's incredibly gratifying, and it's constantly terrifying. Because when you're making decisions that can have a big impact on patients' lives, when you're in surgery, the slightest tick of your hand, especially when you're a retina surgeon and you're working directly on the retina, can make or break a person's life. Every once in a while you're doing surgery on patients that are monocular, that only have one functional eye, and it's your job to restore vision in that eye surgically, and there can be nothing more terrifying than that. But nothing more gratifying, I think, when you realize that you've had that kind of impact in somebody's life and it's been positive. And
Absolutely. I can just describe the impact as night and day, because literally, sorry, I couldn't resist. What is the best part about being an eye surgeon?
I think there are a lot of things about what I do that are very gratifying. I think the most important one, I think, is it's the impact that you have on people's lives. And with the treatments that we have now, we can have such a positive impact, and we can make such a difference. I mean, retina used to be a field where we were very limited in what we could do for patients. And, 20 years ago, except for a few things surgically and that kind of thing, we would often tell patients, I'm sorry, you have a blinding disease and we can't do much for you. And patients would come in for checkups and you would watch them lose their vision. And now we have therapies that can actually improve the vision, help patients recover their vision, help patients overcome the disease and live life more fully. And that's very, very gratifying. It is not immediate gratification. It is delayed gratification. You don't see an effect immediately, and that's something that patients have to understand, and the doctors that treat these patients have to understand, is that very often it can take 6 months before you really start to see the benefit of what you're doing, sometimes more. But it's worth the wait.
Absolutely. It's very interesting. I always think about how, when I saw the patients in your office, and how they would mention to me how what an amazing impact you had on their lives. And they were saying, oh yeah, Dr. Velez, I've been seeing her for so long, and she's saved my eye, my vision. I can now see much more now that I'm getting the injections. These injections are a real breakthrough, it sounds like.
They are. They've really changed what we do things and how we do them. And the standard of care has changed dramatically. I know in macular degeneration, the injections are the standard of care, and we have several that we can use. But they've been a godsend. I mean, I have patients that I've been treating. I have 92-year-old patients that have been getting injections for 12 years, and they're still reading, and they're still driving, and they're still living full lives, and they still have active wet macular degeneration. You take the injection away, the leakage comes back, the fluid comes back, the vision drops, and you maintain them with those injections with 20/30, 20/25 vision, and excellent reading vision. That's what that is. And they're able to just live. In diabetes, it's the same thing. The paradigm has changed from a laser-oriented treatment protocol to an injection-oriented treatment protocol. We know from the clinical trials that we have out there, both through pharmaceutical companies and through the NIH-sponsored DRCR group, that injectables give us the best outcome, short-term and long-term, in these patients. They're a lot more work. They require a lot more patience, both from the doctor and the patient, but the rewards are tangible and really just worth the investment. So it's these injectables have changed what we do and how we do it.
Wow, I'm just fascinated, and I know it's quite an advance now over the previous treatment, right? It was they did laser or something like that.
Right. So laser still has a role in very specific situations, but it is not the primary treatment that we go to in diabetes anymore. Especially when we're talking about treating the center of the vision. And I think the clinical research protocols that are out there confirm that. And with a lot of patience and a lot of hard work, you can spare, you can spare the patient the permanent scars that they would get from laser, which would give them permanent defects in their vision that you can't get back. And that's why I think these injectables are so fascinating and so miraculous, really.
Yeah, remember you showed me there was the difference between the patient who had the laser treatment, their retina, and then the patient who had the injections. And it was, of course, the laser patient had, it was good, they could see, but it still looked really messy on the screen.
Well, in the center of the vision, when you apply laser, what you do is that you create permanent scars that create what we call permanent scotomas, empty spaces where there's no tissue anymore and you can't see. When you apply heavy peripheral laser, you constrict the peripheral visual field, so patients basically have less side vision. And you have a significant impact in nighttime vision. So your ability to see in the dark is significantly diminished. And these are permanent effects of laser that never go away. These things are never recovered because what laser does basically is create a burn in the tissue that paradoxically helps control the progression of the disease, but it's through damaging tissue or permanently burning tissue that's damaged. What the injections do is that they actually help reverse some of that damage. So you don't have to burn that tissue anymore. You don't have to create those scars. You don't have to constrict the visual field and permanently damage nighttime vision in your patients when you can reverse the damage using the injections and maintain that previously damaged retina healthy.
Wow, absolutely. It's well said. You are a fascinating person.
Thank you.
And I just want to say thank you for opening my eyes to the field of retinal surgery.
Oh, you're welcome. Anytime. Anytime.
Thank you.